Welcome to today's webinar. This webinar is sponsored by Mizuho OSI, a leading manufacturer of specialty surgical tablers and pressure management solutions. In this webinar, we will learn the importance of consistency when moving from the hospital to ASC setting, efficiency in the ASC, and keys to effective patient communication. It's my pleasure to now turn the floor over to our presenter, Dr. Charles DeCook.
Well, thanks for the introduction, and thanks to Beckers for having us on today. I'm certainly excited to be with you this morning and to talk about some of my passion around the ASC and total joints and really driving value. I also want to thank this morning Mizuho OSI for hosting us and sponsoring this event. They've become leaders in anterior approach replacements and certainly will be in the ASC as well. These are my disclosures, all of which are pertinent to the presentation I'm giving today, including my paid consultancy through Mizuho OSI and stock options as well. I'm also owner of my ASC. So, as you know, surgeons have a job to do. And that job to do is enabled by different technologies and different venues in which we operate. But the real key and the thing that I want to drive home today is that it's the surgeon's job to truly drive value in today's healthcare. No one understands this better than Michael Porter. For those of you who have not read his work, this is a must in healthcare of today, and that is truly appreciating value.
Are we organized to deliver care that maximizes value? Are we measuring it so that we actually know whether we've delivered it?
Value has to be our true north moving forward. And it really is our identity as physicians and surgeons now. Not only is it about outcomes, but it's also about the costs in which we incur to achieve those outcomes. And that is our true value. That is our fingerprint as a surgeon, as a joint replacement surgeon, but frankly, as any physician today. You know, and the secret of care of the patient is obviously caring for that patient. It's a quote I love. So that has not changed at all. And that is the most important job we have, is to care for our patients. Our outcomes are obviously number one. And it used to be that I could just say my readmission rates were low, or that I had a nebulous sort of outcome. But today I have to know exactly what my readmission rate is. I need to know exactly how much I'm costing my health system. It's a different world in which we live today, and that has to do with value. And that means that I can no longer separate my outcome from the cost in which I incur to my health system. One of the things important that all surgeons have to appreciate is that we are the ones that are going to drive value in the future. And we drive that preoperatively by determining where we operate. So me as a joint replacement surgeon, if I choose to operate at a hospital, it incurs a certain cost. Whereas if I operate at an ASC, it incurs a different cost. And I have to be aware that my choosing the venue in which I operate ultimately drives that value. This is a great book by Clayton Christensen. So those of you who have not read his work have to do it, especially with regards to healthcare.
This morning, and that is, we need to rethink the roles that the various venues and the various caregivers play. Because it's only by enabling lower cost venues of care and lower cost caregivers to do more sophisticated things. That's the mechanism by which healthcare can become affordable and accessible.
The mechanism by which healthcare becomes affordable and accessible. That's the key there, right? So if you think about total joints and the cost around 90 days, the true cost, the most important cost, happens the day of surgery. That is where the vast majority of the cost happens, and where we choose to operate ultimately affects that cost the most.
Have we thought about our health systems in a way that's aligned with value? Do we have the right service in the right location?
The right service in the right location. So the question is the hospital the right location anymore for me to do a total joint? So you think about these wonderful places in which we've trained, New England Baptist, Johns Hopkins. These are where we learned to be surgeons, right? We learned and trained and got our education at these large institutions and hospitals, right? We learned to round here. We learned to keep patients in the hospital. And frankly, the first total hip was done here, right? In Wrightington, right? So these large institutions have been around for literally over 100 years and have taught us how to become surgeons. But they come at a price.
During the first 3 or 4 days, the patient remains on simple skin traction, but the weights are removed for active assisted exercises. Walking is encouraged after a week, at first with the aid of a frame. Most patients leave hospital between 2 and 3 weeks after the operation has been performed.
So we've certainly come a long way since that video was produced in 1967, but this hospital model has been around and has been a part of us. The problem is this hospital model now is filled with inefficiencies, bureaucratic nonsense, and cost. And that's just a fact that everyone knows. It also comes with bacteria and viruses now, and the dreaded dogma. So all these things, unfortunately, have left many of us surgeons wanting. And this hospital model has been deep within our psyche for a long time, and that is we've had all these different options after we operate on someone, what we can do. We can send them home or an ICU or keep them overnight. I have all these different options available to me as a surgeon. And with those options, if a family member has a concern, or a nurse on the floor, or a stingy old therapist, or if it becomes late in the day, or there's transportation issues, or if a patient has a problem like nausea or pain or weakness, hypotension, urinary retention, if any of those things happen, what happens? We have a delayed recovery and we keep them in the hospital. So this old model, this hospital model of a short period of preoperative preparation followed by a short surgery, followed by this long recovery, has to change. And that's where the ASC comes in. And that is, we have to lengthen the amount of time we get a patient ready for their surgery. And by so doing, we decrease their recovery time. So preparation is key. And frankly, it's complex for us joint surgeons, right? So sports doctors did this 20 years ago, and we are now facing these similar complexities as we try and take our complex medical patients from a hospital and operate in an ASC.
I come to you as someone who has been really interested in how I get better at what I do and how we all do. I think it's not just how good you are now, I think it's how good you're gonna be that really matters. I was visiting this birth center in the north of India. I was watching the birth attendants, and I realized I was witnessing in them, in extreme form, this very struggle, which is how people improve in the face of complexity, or don't.
How we improve in the face of complexity. The problem is we still have the same constraints that we had 100 years ago in hospitals, and that is outdated processes, staffing, and cultures. Even if you go to any operating room today, you go to the operating room, you go to the front desk, what do you see there? You see a whiteboard. Can you imagine the logistics in 2020 that we're still using a whiteboard to help move patient flow? This is my operating room, a whiteboard in place, and these are all these staff members not doing anything, just sitting in front of a whiteboard, right? So you can imagine if you're Delta, trying to manage all these flights in and out per day using a whiteboard. It just doesn't make sense, right? So you can imagine all the logistical nightmares that a hospital also has to have. So a hospital has to deal with the same logistics, people going in and out of a hospital all day, ready for the surgery. And how is it managed in 2020? It's managed by a nurse and a whiteboard. And no, it's no wonder that it's frustrating. It's no wonder that hospitals are losing millions of dollars because of these lack of operations. So it's no wonder we get cases canceled all the time, flights delayed in our operating rooms because of the way things are managed. And frankly, it's a surgeon's number one frustration. And that is that we get very little time in the operating room because we spend most of our day in a locker room instead of in the operating room itself. So if you look at a surgeon's weekly hours, very little of our whole week is actually spent operating. In fact, less than 5% of my week is spent actually operating. The rest is all the inefficiencies about what's happening. And ironically, the time when I'm operating, I have the least amount of control of that. So if you look closely, we operate at efficiency rates of 50%. That means I have a block time of 16 hours a week, and I'm only actually operating for 8 of those hours. That's an efficiency rate of 50%. So if you take 50% efficiency, you add that to any type A surgeon, And 100% of us are going to be angry and upset about the inefficiencies of a hospital. And frankly, it's not just my hospital, it's every surgeon, it's every hospital, not just in the US, but around the world. And that is, we have these same outdated processes of staffing and logistics. Now, efficiency, if you look at efficiency from a different perspective, the status quo always works for a time, right? So we've accepted 50% efficiency in the hospital for over 100 years. Why is it different today? Well, if you think about the combustion motor, we've accepted that since Henry Ford came out with mass scale in 1900 of a 28% efficiency, right? It met the demand of the time, but times are changing, right? And with that, new revolutions, evolutions, and new technologies are coming out that are going to demand better efficiency. This is just one example of eVTOLs from Uber Elevate, which demand better efficiency in a motor to allow us to do jet propulsion. So if you think about our ORs today at 50% efficiency, what's going to change? Well, what's going to change is true value. Value is going to be a thing that increases our efficiency. And what better way to do that than in an ASC where we can drive the value?
There's an old Wayne Gretzky quote that I love. I skate to where the puck is going to be, not where it has been.
Where the puck is going to be. So a lot of you have seen this graph that was actually from Becker's that predicted over 50% of total joints will be done on an outpatient basis in 2026, right? Well, the future is faster than you think, especially with COVID, new technologies, economic pressures. That is happening faster probably than 2020. And full speed ahead to the ASCs. Why are surgeons doing it? There's financial motivations, and now there's also biologic motivations to stay away from coronavirus and other things. So if we think about all the hospital has had to deal with in the last 2.5 months from COVID, that is having ripple effects and will continue to have ripple effects all the way to pushing patients to our ASCs. How else do we drive value in an ASC? Well, intraoperatively, it's by the implants that I choose and the technologies I choose, right? So if you look at who is the best at getting down these costs, it's actually the physicians at the table that drive down the cost of implants and technologies, because we ultimately decide which technologies and which implants we use. And it's much easier to find that alignment between surgeons if you have ownership in an ASC. So we can find easy alignment that way. And I'll be darned if I'm going to buy an expensive robot for my ASC when there's no true value there. How else do we drive value? Post-operatively, we drive value by where we disposition our patients, right? So obviously skilled nursing facilities are hopefully a thing of the past, but home health, outpatient PT are also things that drive up value as well. And we have to be cost conscious in today's bundled world. And we know that physical therapy, frankly, has never proven its true value, no difference in range of motion, but look at all the costs associated with it. In this world of value, we can no longer afford to do those things that don't bring true value, and outpatient physical therapy is one. So obviously increasing our value comes at the cost of decreasing costs and improving our outcomes. The true cost obviously is affected by our bundles. So the day in the future where bundles will happen, absolutely will occur, and no better example of that than in an ASC, because in an ASC, I don't have to worry about the costs incurred during their inpatient stay. I don't have to worry about therapy afterwards. I don't have to worry about some of these other administrative postoperative things that bring true cost to a bundle. If we do these in an ASC, those costs go down. This happens to be a picture of our ASC that we built just to do total joints. And the real value of this ASC is one thing, and that is I know the exact cost to take care of a patient that needs a total joint. That is the value that it brings. And we can define our pathways and reduce reductions in cost. So if you look at this paper, over $3,000 of improved income and decreased costs as a result of having defined clear pathways for every surgeon at the ASC. So financial success for surgeons obviously has always been traditionally been considered professional fees. However, there's new ways of financial success, and that is facilities fees from ASCs and controlling bundles. That is the pathway to the future in terms of having viability for physician salaries moving forward. So we have to drive value, and one of the values obviously in the ASC is patient satisfaction. So if you look at this study, obviously HCAHPS scores, ASC wins every time. And why is that? Well, I call this the in-law rule, and that is if your in-law is there at your house for more than 4 hours, there's a problem, and they start to have more and more problems themselves. And same thing in an ASC or hospital. If you keep these patients, the longer they're there, the more they realize the faults associated with them.
If today you've improved outcomes without escalating any cost, you've succeeded. Today, if you've delivered equally good outcomes more efficiently, you've succeeded. Today, if you didn't do one of those two things, you failed today.
So don't fail today. We have to truly drive value. I want to switch topics just slightly and talk about another great thing, and that is the Medici effect. The Medici effect says that all great technologies and innovations come from taking two disparate fields and combining them together into new ideas. So let's take that idea and bring this to healthcare, right? So if you look at Henry Ford here, how was he effective at what he did, right? Obviously, he developed the moving assembly line, and he's most popularized for that. But the true work of Henry Ford was figuring out how you move the work from one worker to the next to become a complete unit. That's the real brilliance and genius of Henry Ford. How can we apply that to healthcare? Well, frankly, although we don't like to consider our patients on an assembly line, it's absolutely surgery is an assembly line. And that is there's a defined set of parts that move in a certain order to get something done, right? So we have to take these ideas that Henry Ford have and how can we apply this and get more effective in our operating rooms, right? And one of those things is consistency, right? Doing the same thing every time the exact same way. That consistency through these tools allow us to have more reproducible results. So if you look at Steph Curry, the best way is to do it the exact same way every single time, right? That's how Steph Curry shoots the three-pointer so well. He does it the exact same way every time. And frankly, surgeons are the same way. So the reason why high-volume surgeons have such good outcomes is one thing. We do it the same way every time. That consistency, that reproducibility is key. So if you look at this picture here, this is an anterior approach being done on a OSI HANA table with a fluoroscopy machine. Doing it the same way every time, having consistent femoral exposure on a total hip, the same way, regardless if you're at a hospital or ASC, is the key to consistency. So this is the whole team, right? So obviously not just the surgeon, but everyone on the team has to be consistent. If you're off and you're not consistent in what you're asking of your team, then your team is going to be off, right? So what does consistency look like in the OR? I call it flow. So the flow in my operating room is really my ability to focus on what I need to be doing, and that is surgery, right? I feel like I'm in the zone if everyone on the team is working with me. But if there's an interruption, a phone call, or I've got a new circulator that forgot to plug in the Bovie, or an x-ray tech that I've never worked before, or a scrub tech that hands me something on the wrong setting, I lose focus. And what happens with that loss of focus, it decreases my ability to focus on what I need to. Because frankly, no one is able to multitask, even surgeons, right? So as soon as that focus comes away from my operation and I have to focus on something else, I lose time and effort. So that consistency of teaching not only myself, but teaching all the staff members, whether it's order of instruments or Mayo layout, all those things are key. And you have to be a surgeon leader to do that, to enable other people on your team to focus on their thing. Because if you want to be fast and efficient in the operating room, it's all about having consistency in your team. If your team cannot help you do it, then there's chaos. Now, what better an example of this effectiveness in the modern world is Amazon, right? If you ask yourself, this is an Amazon factory, if you ask yourself, does your hospital or your ASC even, does your OR look like this at all? And probably the answer is no. And the question is, why not, right? Well, let's talk about things that we know. What are the metrics of efficiency that we know about? Obviously, turnover is the one that's talked about the most. And it's traditionally defined as wheels in, wheels out. But really, wheels in, wheels out is totally fooling you. So don't get fooled in that. Turnover is really not wheels in, wheels out. That has been a dogma, which unfortunately it came from hospitals, which is wrong. True efficiency and true turnover happens when you finish your surgery. So when that wound is closed, that's when the timer starts, and it ends when you make incision on that next patient. That is the true definition of turnover, and that's what every surgeon should mandate that hospitals and ASCs use. So we need to rethink efficiency. So oftentimes we think about operating faster. I will tell you that is the wrong way to think about efficiency. It's really about operating more. So when I'm staring at this picture, I am not operating. The surgeon is not operating in this room. There is a problem right now in that room, right? No one's in that room. And if you go to ORs across the country, this is the problem. This is where our time is truly lost, is right here. So Stephen Covey, a great book that I'm sure many of you have read, and that's reactivity. We cannot be reactive, right? So a lot of surgeons say, well, I can only do 3 cases in a day, and there's no way the hospital can support it, and I never have the same team. They just don't get it, right? So these quotes I hear all the time, but it's really not about operating faster. It's about organizing your team around what you want to do, right? You are the leader, and you have to automate the team around you so you can stay focused on what you want to do. Automating that surgical process from the time that patient walks in to when they leave is key. Getting every single staff member on your team in order, in line, at the right time is the key to this process of efficiency, because when I'm operating, I can't be thinking about what the orderly is doing in the hallway or my scrub tech in my next room is doing. There's these simultaneous actions going on right now, and I have to stay focused on what I'm doing, right? So instead of that, we need ways to keep an eye on how much time we're spending. How long does it take to get a patient to go from check-in to actually getting the pre-op, right? Or how long does it take that anesthesiologist to put that patient to sleep, or that spinal, right? How long are all these things doing? We'll never know this stuff if we're not measuring time. The problem is there's no transparency of how long these things take. And that goes from the surgery to all the way to room turnover. All these different steps have to be measured from time perspective. I need timers and clocks on these scrub techs that I work with, these nurses, to know exactly what they're doing with the time that they spend during the day, right? So it's not just how long the surgery takes and how fast I can be in the OR. It's all the other things that allows me to operate more. That's the key. Allow me to focus more. To do that, we really need better radical time transparency. We need to be able to measure time in the OR, because every second I'm not operating is time lost. So if you look here, right? Anesthesiologist isn't in the room. They're not ready to cut, right? Opening a case, we were shocked when we started measuring time much more effectively. We didn't realize how long it took for a scrub tech and a circulator to open up for a total joint. It's unbelievable, and it will floor you to realize how much time you lose during this process. So that lost time equates to lost value, right? And why is that? It's because our effectiveness really has to do with how good our efficiency is in the operating room, right? And these two go together, efficiency and effectiveness, and they go together through time, right? Because the more time in the OR, infections go up, DVTs go up, complications, readmissions, right? There's a biological reason, not just a financial reason, why we have to operate efficiently, right? Because ultimately the point of surgery is to actually finish the case. And there's this pull and tug sometimes between effectiveness and efficiency. And you have to ask yourself, how effective am I truly being, right? So the first thing from the 7 habits is to first understand, and that is, what does your cup position look like? How's your leg length doing? Dislocation, wounds, infection, all these things that are good surrogates for how you are as a surgeon. You have to understand and know your own data. You have to look inward first to appreciate how effective you are being. And it's nothing different than Henry Ford walking his plant and looking at those Model Ts and saying, how close did I get every single time doing exactly what I wanted to do, right? Sharpen the axe. Give me 6 hours to chop it down. I will spend the first 4 hours sharpening the axe. Abraham Lincoln. Truly important. How does this apply to operating room and efficiency? How do you sharpen your axe in the OR? Really sharpening the axe is about making your team one team, right? Making everyone on the same page. That's the part about sharpening your axe. So each team member has to do their job, and they have to do it at the right time just in time. These principles apply to simple logistics and companies, and applies to our operating rooms as well. And that is, we have to deliver our service just in time. And that is the key, because if it doesn't happen just in time, there's a ripple effect. So if that person doesn't go in and clean that operating room just in time, what happens? It causes delays down the road. And that ends up being that I end up only doing 3 cases in a day. And that just cannot happen. Your whole team has to deliver just in time for that to happen. Atul Gawande, you have to read his stuff, because we have to really appreciate how to do better
at what I do and how we all do. I think it's not just how good you are now. I think it's how good you're going to be that really matters.
How good you're going to be is key, right? So if you think about surgeons, if you think about a tennis player, how do I get better at playing tennis, right? I take a lesson. I learn, I practice, I keep going, right? Golf, same. Learning how to play a violin, all the same way. So if you think about our medical training as surgeons, right? We go through all this training and residency and sometimes fellowships, but my entire career, the only person that really knows if I'm any good at operating is myself, right? What's after that? What comes after fellowship? How do I continue to learn and grow and improve? And I think that's Atul Gawande's point, right? So sometimes what we do in our operating rooms and what we know to do are 2 different things. That defines our effectiveness, right? So that's the key, is really appreciating that, right? How do I improve, whether that's native femoral version or femoral offset, or how flexible is their spine? What's the best hip center? These are all questions that we don't know the answers to right now. But we have to keep asking as surgeons, how do we improve at these things, right? It's sharpening our axe. To do that, we have to do things consistently in the OR to do what we need to do. And no better way to do that than the anterior approach with total hips than the MATA method, using both fluoroscopy and the Mizuho OSI HANA table, right? So when I consider moving to the ASC, there's some important things that I always consider, and that is avoid change, right? And that means I need the same surgeons that are operating, the same anesthesia, the same OR staff, the same equipment, the same implants, right? It's a bad idea to get this idea, well, I'm going to try a new approach like anterior approach in my ASC. Bad idea. A new technique, right? A new cheap implant, right? Where you think you're going to save on cost and improve value by picking a cheap implant. Doing these things in ASC is a bad idea. New anything, frankly, new underwear is a bad idea. If you're trying to convert from a hospital to an ASC, you have to have the consistency of doing it the same way every time. And it's a stepwise approach. The first approach is in your hospital is you have to decrease the length of stay. If you're not used to sending someone home the same day, just decrease the amount of time you keep them there. If it's 2 days, go down to 1 day. If it's 1 day, go down to 18 hours and then 12 hours. So reducing length of stay first. Then you go to decreasing in the hospital. Then you move to outpatient in the hospital, right? So before that first case in ASC, you need to practice at the hospital and do that. And then eventually the final step is doing outpatient in the ASC. To do that, you have to assemble the right team, as we talked about, modify your protocols, and practice in the hospital first. And we've done this now at ASC, and we've done outpatient total joints now for 7 years. And our philosophy now is quite simple. And that is, if you're now healthy enough to have a total joint, you're healthy enough to go home the same day. That's our philosophy, and that has worked well for us. So these are our numbers. We did close to 2,000 total joints, and over 98% of our total joints went home the same day, applying those simple principles. So our feeling is that the vast majority of primary total joint arthroplasties are candidates for outpatient surgery. And I think with that, I will close. I just want to close with my parting thoughts is we surgeons drive true value in healthcare, and we drive that value by deciding not only where we operate, but the tools in which we use to operate. And I think I'll close, and I appreciate everyone's time and efforts, and thanks for Becker's and Mizuho OSI for putting this on. Thank you very much.